And so many of you are find your way to the cath lab at one point or another about what the latest and greatest is in our world. It's not just a dark place where scary things happen. But in order to talk about that, I wanted to take a couple minutes and talk about how the purpose, the role of the cath lab has changed over time from what it used to be to what it is now. So in the old days, and by the old days, I mean the 1970s, that area, the role of the cath lab was diagnostic. Nearly every child received a heart catheterization because other than the doctor's physical exam, and their skills at physical exam were probably far superior to mine since I'm spoiled with all this technology, that was the way to verify what you thought was wrong with the child. You could make your diagnosis in the cath lab, you would understand their physiology in the cath lab, and it would tell you whether or not they needed something done, did they need surgery. And so children got cathed. Most children got cathed, most children got cathed more than once. And then as ultrasound expanded, technology improved, and our ability to diagnose things through ultrasound and echo improved, then we started to rethink whether or not the cath lab was the right thing to do on every child, because echo doesn't hurt, doesn't expose you to radiation, doesn't require the child to be sedated unless they're really crazy. And people started to wonder how often did we really need to use the cath lab anymore. An MRI was on the horizon. An MRI was going to be better than echo. MRI was going to show you everything straight through the chest, every structure, how they interact, how they move. It was just, you know, the new world order of congenital heart disease. And really, other than diagnostic procedures, there were really only two things we did in the cath lab other than diagnose and take pictures. And that was notably, and not inconsequentially, was balloon atrial septostomy, which, for anybody familiar with transposition, was a procedure to open up a hole between the two chambers of the heart and allow your blood to mix before you could have definitive surgery. And that was a life-saving procedure. And then in the late 60s also was the publication of closing blood vessels, specifically the patent ductus, with small embolization coils. There wasn't a lot of evolution, though, in what we did in the cath lab from the late 60s to the early 80s. And the naysayers in the room were deciding that this was a dinosaur. The cath lab was this archaic place, and it really didn't have a role anymore, and you probably wouldn't want to go into that even if you like it, because you're not going to have a job. But about the same time, the people that actually worked in the cath lab were also evolving and changing what they did, and there were some really pivotal decisions made in the early 80s, and they were published in the New England Journal of Medicine, the American Heart Journal, Circulation, and those were the first publications which actually treated the heart disease in the cath lab. Pulmonary valvuloplasty, published in the New England Journal from Johns Hopkins in 1982. Aortic valvuloplasty with a balloon, followed in 1983, and also balloon dilation of coarctation. And then Jim Locke's paper from Boston Children's in 1983 with balloon dilation of small and underdeveloped pulmonary arteries. These were all absolutely landmark publications, and 3 of the 4 are now the gold standard, the treatment of choice for all of these diseases. Isolated congenital pulmonary valve stenosis, aortic valve stenosis, is treated with balloon valvuloplasty. And our primary goal with pulmonary arteries that are too small is to dilate them, stent them, take care of them without having to send the child back to surgery every single time, although sometimes surgery is still the best option. Chuck Mullins at Texas Children's published the first stent paper in 1988. And for resistant lesions where the balloon just wouldn't do the trick, they started to implant these little wire mesh frames to get the artery to open up and stay open. And then in 91 was the first sort of review article about stent use, and that included the first use of stents in coarctation of the aorta, which is now for isolated coarctation the treatment of choice, other than in the newborn period. So when people thought the cath lab was dying, the cath lab wasn't dying. The cath lab was changing from a primarily diagnostic lab to a lab where you would confirm problems, but then hopefully also treat a lot of them anyway, and take care of them. And then in the 90s and the 2000s, there was just an explosion of medical devices and products and techniques, interventions to treat all sorts of things. And this isn't actually probably even half of it, but there's easily, what do I have on the screen, 6 or 7 different devices for closure of the patent ductus. There's 4 or 5 different devices, not including coils, and coils are not just one thing. A coil isn't just the little picture of the little spring that I have on the screen here. There's a shelf of coils, all different lengths, materials, coatings, to, you know, some that are attached to a catheter, some that are freehand deployed to do different things for different people in different places. It's remarkable. Not all the companies survived. We loved it when companies were willing to invest in pediatric patients and in congenital heart disease, because that's the problem. There's a big market for adults that have heart attacks because there's a lot of them and they have money. But congenital heart disease is a boutique industry. It's a small population. It's not the big money maker for the medical products companies, so we need people to make products for us. And these companies took the risk. Not all of them are still around today. But they were willing to do it and willing to try. And then the big change came also when we started to close holes inside the heart. That was an absolute surgical thing. And then we started to close ASDs, PFOs, VSDs in the cath lab. And there's 4 products in the United States that are FDA approved, and everything in the United States is harder than everywhere else in the world. If you go to Canada, you go to Mexico, you go to Paris, there's 2.5 times as many products on the shelf, because their approval system is easier, which is good and bad. But they do have access to the cool toys quicker than we do. As devices evolved, like I said, the first thing we started to do is we started to blow balloons up in things. And then balloon technology, you wouldn't think balloon is that much technology, but it is. Because the balloons, if you're going to put them in a baby, have to be reliable. They have to be a very specific size. They have to inflate to a very specific pressure. You've got to be able to trust that the balloon is what it's supposed to be. Our bread and butter balloon is the Ty-Shack balloon. The Ty-Shack is an odd name, and that's because it's a combination of 2 doctors' names, Mike Tynan and Shaquille Qureshi, who are interventional cardiologists. Both of them are still practicing. They were at the meeting I was just at in Miami, and tremendous, tremendous people. The Z-Med balloon is a less compliant balloon. It's a harder balloon, so it's used to dilate more resistive lesions. And the Z stands for Ziad Hijazi in Chicago was the innovator who designed that balloon. The bib catheter is a balloon-in-balloon catheter, which is designed with a balloon that surrounds a second balloon and allows you to inflate a stent. It's specifically a stent deployment balloon, so that you can take a stent up gradually and precisely and get it in the right place. And then we get into the stuff that sounds a little crazy, but some of these lesions we have to dilate are extraordinarily resistant, and they are hard to break through. And so we have cutting balloons. We have balloons with little, they call them atheratomes, which are razor blades on the outside of the balloon that are meant to cut into the fibrous tissue and the scar tissue and score it so that you can break it open and get it to expand, because it is so rigid that you can't touch it with normal pressure. But if you cut it first and then go back in with the high pressure balloon, you can get it. And then we have our strongest balloons, which have cool names: the Conquest balloons, the Dorado balloons, the Atlas balloons. These are balloons that have Kevlar woven into the fabric of the balloon, and they go to extraordinarily high pressures. The Atlas balloon is our largest balloons that go to the highest pressure, and you can go to 18 to 20 times atmospheric pressure with that balloon without the balloon rupturing. So you can really hit it hard. And the Conquest balloons, because it's a smaller profile, is actually higher pressure than the Atlas. They can go to 30 times atmospheric pressure. And you wouldn't think that a little scarred blood vessel in a 2-year-old child could need that kind of pressure. But I've used them on 2-year-old children, and where nothing else would get it open. They're really amazing. So if we were encroaching so much on the surgeon's turf by stealing surgical procedures and doing them in the cath lab, the natural evolution of that is for the surgeon and the interventionalist to start to figure out that there's aspects of what we do that are an advantage, and there's aspects of what they do that are an advantage. And sometimes neither procedure is perfect, but a combination of the two might work really well. And so hybrid procedures, or procedures where you do part of it through surgery and part of it through an interventional technique or a balloon dilation, were the next evolution in what we did. And this gave us the opportunity to approach things that were either extraordinarily high risk for me or very difficult for the surgeon, because getting into that part of the back of the chest would require such extensive dissection. We can have just slide the balloon back there, we can hit it, and then leave all the surgery for up front. It really has been nice, but what it requires is, number one, a surgeon and a cardiologist that work well together, and we're fortunate that we've got such a great group here between our surgeons and our cardiologists, that everybody is on the same page. But you also need to have at least base level equipment that works together, because the cardiothoracic surgery is an extraordinarily specific and technically precise field, as is interventional cardiology, and unfortunately all this stuff is different. And so it has to be designed to work together, and you need to have advanced imaging and a full-out OR in the same space. And we're blessed in Omaha that we have that space. In fact, we have one of the best ones in the country. We have a full hybrid cardiothoracic operating room, dual exhaust, chrome headers. It's advanced. And it's 1,000 square feet, which is huge for a cath lab. We can have an ECMO pump, perfusion, anesthesia, everybody in the room, 2 full teams. It's great. And we've got folks that, obviously this is, the room just panning around. We've got a Toshiba 5-axis imaging system, which we actually have a contract with Toshiba to use it as a show site. So when they're trying to sell cath labs to other places around the country, they bring them to Omaha and show them our lab as a sample. And in return for us letting them use our lab as a show and tell, they upgrade our equipment and give us all the new toys. And this is just a picture of Dr. Hamill and I doing a procedure together in a hybrid situation. But one of the things that's tough, well, first of all, just the numbers. So we do about 20 hybrid procedures per year. And that number is growing. And we do everything from dilating difficult to reach branch pulmonary arteries, stenting the PDA open on small babies that are too sick to get their definitive surgery, pulmonary valve perforation and dilation for completely atretic pulmonary valves, exit angiography, which means a surgery's been completed. The surgeon wants to be absolutely sure before they leave the operating room that the repair is what they think it is. And so we take pictures of it with the x-ray cameras and the angiography before they're done, while the chest is still open, so that if they need to revise it, they know right away and can do it right then. And Dr. Hamill and I actually published the article below. This is a shameless plug. We had a very unique little child that had a arteriovenous malformation in her head, and she had multiple communications between the atrial septum. The problem is that one of the communications precludes using a device. It's not safe to put a device in it. And with an AV malformation in your head, you can't go on bypass. With a communication in your heart, you can't have the AVM treated or you'll induce a stroke. So we did a hybrid procedure where we closed the holes through an open chest with multiple devices, and the hole that normally wouldn't be closed with a device isn't stable because it doesn't have a rim on one side. So we put that device in, and then while it was still attached to the cable, Dr. Hamill sewed it to the edge of the heart, so it's not going to move. And she's now 4 years old. Her AVM's gone. It's been treated. Her heart's fixed. She's never had another surgery. It's really, really a cool story of people working together. But one of the problems with that, one of the problems with a hybrid room is my table is an x-ray table, and you can see through it with x-ray cameras, and it moves like an x-ray table. Dr. Hamill's table is made of metal, and you can't see through it, but it does cool stuff he likes. It rocks towards him if he wants to move the baby a little this way so he can see better. And it moves the other way, and it goes this way and that way. And so he doesn't like doing surgery in my room as much because it's harder for him. So that was an impediment to us doing all the sorts of cases we would like to do, because you need to have everybody feel that they're as comfortable and can offer the same advantage as they would in their own space. So, and that was a surprisingly hard nut to crack, was to make a table that works for X-ray be a table that worked for the OR. But they did. And so we've just installed this, the Infinity I Cat 880B, which is just a table. So I'm here giving you a speech that we installed a new table, but it's a special table. It does all sorts of things. It moves all the kinds of ways the surgeon would want, and it's completely X-ray compatible. And it can do all these sorts of things and move all over this pedestal as long as you weigh 500 pounds or less. So it's really an impressive thing, and we just installed it a month ago, and it's going to be just take our lab that much higher. So I wanted to take now the opportunity to show you two patients that we've done in our lab, standard interventional procedures, branch pulmonary artery stent angioplasty and coarctation stent angioplasty, because I wanted to highlight those things and then show you what's coming, which we're in the process of installing right now, which will make procedures like this hopefully easier and smoother to get a good result. Both of these patients, I think, got a great result, but we've got new technology that will make that easier. So this is a 3-year-old little girl who had pulmonary atresia, had several procedures between surgery and the cath lab trying to make her pulmonary arteries grow and make everything work. And as you can see on this X-ray, the left pulmonary artery is nice and big. The right pulmonary artery isn't as big, and this part is all scarred, and I've ballooned that several times, and it just didn't want to stay open for her. And it's big out here. That's nicely sized, but all the way back it's not. So we laid these stents in, 2 telescoping stents to go all the way from the hilum of the lung back to the pulmonary bifurcation. And when we started, she had 80% of the blood flow to her left lung. When we were done, she had 50. Between 45 and 55, depending on the perfusion scan. So it really worked great. So this was a very nice result for her. Now she's 3. The stents are big enough to go to adult size, but they're not adult size now. So we know that when we do this, we are committing her to catheterizations in the future, because when she grows, the stents will stay the same size, and then we'll have to touch them up. We can do that. The stents can be expanded down the road, but we have to bring her back in 4 years and knock them up by 1 millimeter or 2, and we'll do that several times. But that ended up working out really well. Next patient, this is a 15-year-old guy, big strapping boy, who presented with high blood pressure, and as it turns out, he's got a napkin ring in his aorta that was just tight as a tick, that had been not diagnosed even since early childhood. We pick up most of these in infancy, some in childhood, but occasionally we do adolescents and young adults that have been missed their whole life. And so you can see this tight lesion here. And so what we did is we did more than that. So I'll get those playing again. So this is that balloon and balloon catheter. The inner balloon is already inflated. What the inner balloon does is it allows you to start to dilate the stent, but you're not committed yet, and then you can reposition it if the stent starts to move or you're not in the right spot. And then here's where we bang it up to full size. And now here's the result. So this works great. So he's doing really well, and I think since he's already taller than me, I don't think we're going to need to necessarily take this bigger, but we'll watch for that. And we see him back. So both these worked really well, but as you can imagine, what I'm telling you is, in both these patients, we laid stents in, and stents are permanent. Once that stent goes up, they own it, unless they have surgery to take it out. So you got to get it right. You got to get it in the right place. You don't want it too deep. You don't want it too proud. You don't want it to interfere with other adjacent blood vessels. And we're using our understanding of the anatomy and our experience, just by doing this a lot, to make decisions based off incomplete information. We've got an image in an anterior plane, we've got an image in a lateral plane, and we're creating in our mind a 3-dimensional reconstruction of what that blood vessel actually looks like by taking those pictures. But wouldn't it be nice if we actually could have a 3-dimensional reconstruction of that blood vessel and look at it and spin it around before we lay the stent in, figure out what the exact best angle is, and then lay the cameras exactly at that angle and do the procedure. And that we can actually do now. So three-dimensional rotational angiography is a new technique where you lay one of the cameras totally at the back of the room, you use the anterior camera, and you give a pulsed injection of contrast that's a low dose over a longer period of time, and the whole time you're injecting it, it's over like 5 seconds. The camera is spinning around the patient and it's taking pictures. And then after it takes those pictures, then it all goes back to the computer console where all of those images from different angles are processed and combined, and then you get a three-dimensional picture of the blood vessel that you can then spin around and turn and look at it every which way. And when you decide what the best angle is, you hit a button and the cameras go to that angle, and then you do the procedure directly from that angle. So it's the coolest thing ever. So this is a picture of the gantry on the AP camera moving all around all of those angles, taking the picture. I should say that one of the things we also do is we pace the heart rapidly during the injection, because if you pace the heart rapidly, the amount of blood flow, the amount of blood ejected on each heartbeat goes down, and your contrast will be darker on each heartbeat, so you get a better picture. So this is a patient. These are from Miami Children's. This is Evan Zahn's lab, and he and Toshiba agreed that I could show you these pictures. This is a branch pulmonary artery stenosis, not unlike the little girl that I just showed you. But this is a three-dimensional rotational angiogram. This isn't an MRI picture, a CT, even though it looks like it. And you can take this and then you can spin it, not only in the vertical plane like I'm showing you, but you can turn it horizontally, you can turn it off axis. And if I freeze at any point and say, okay, yeah, that's where it looks the worst, then I can turn the cameras to LE07 caudal 56, which is never an angle that I would have decided on, and do my whole procedure from there. And then I can superimpose this image over the live fluoro camera so that as I'm moving the catheter, I'm moving it through this image, and I know exactly where the lesion is. And then once you do your stent, you can take another picture and look at it and admire your handiwork and see if you're happy with it, and see if you need anything else. So here then is coarctation, just like our other guy I just showed you. Now this one isn't a rotating picture, it's just a still frame, but it shows you this is a three-dimensional lesion. It's bulgy in some areas, it's tight in some areas, and if you don't get the stent just right, if you hang it too high in the arch, that's going to be a problem if you don't capture the whole area. And this is a different size than this, and you got to get it right. And I think they did get it right. This looks excellent, which is probably why it's one of the ones they let me have. But it looks great, and this shows you that. And then this one is the one that rotates around and can show you from each angle whether or not it is what you think it is and what else it would need. So three-dimensional rotational angiography our lab has, and it is in the process of being installed. It's technically, you would think it's just a matter of plugging in new software or something, but it's a lot bigger deal than that. So they're in the process of installing it, and hopefully it will be soon. I've done a lot of talks over the last year on percutaneous valve replacement, because all of the things I've told you about so far, blowing up balloons, beating on scars, dilating stuff in the cath lab is easy. Preserving valve function is not, because most of the time if you blow a balloon up in a stenotic valve, you know that one of the prices you're going to pay is the valve's probably going to leak a little more. That's the price you pay for it opening better, is you'll have less blockage but more leakage. So we've not been able to treat leakage in the cath lab. And so if a person didn't have a good valve, or their primary problem was leakage, or it was a combination of blockage or leakage, we could get rid of the blockage, but we couldn't treat the leakage, so that was surgery. And surgery has been a problem for valve replacement, as probably some of you guys know. If you replace a valve, it doesn't last a lifetime. No valve you put in surgically lasts a lifetime. Unfortunately, they don't last anywhere close. They last 5 to 15 years, and then that valve degenerates, and it either becomes blocked, or it becomes leaky, or it becomes both. And so we have not been as aggressive as we would have liked about sending our patients to the OR, because you can't send them to the OR every 5 years. That's a lot of surgery over the course of your life. And so we have taken a bias towards keeping the valves working as good as we can for as long as we can, because surgery's hard, and it's not a free thing. There are complications, there is stuff that you have to go through. But Philippe Bonhoeffer is an interventional cardiologist in Europe, and he took the Contegra bovine jugular venous valve, which is a surgical product, and he sewed it inside a balloon expandable stent, and he put it in some pigs, and it worked. And so then, because you can do this in Europe, he put it in some people. and it really was an impressive deal. And Medtronic makes the Contegra product, and they became very interested in it, and they purchased it, and that is the Melody valve. The Melody valve is named the Melody valve because Philippe, in addition to being this amazing cardiologist, is a virtuoso violinist. And he didn't want it named the Bonhoeffer valve or the Philippe valve. So they named it the Melody valve. And so this valve is identical to the surgically implanted valve. It can be crimped down to 6 millimeters on the balloon so that it can go in through the venous system, through the groin, and we can slide it up across a dysfunctional outflow tract, and then it can be blown up to anywhere from 16 to 22 millimeters, and most of the adult valves we put in are 20 to 24. And it's just mounted on a large angioplasty balloon, a bib balloon like the one I showed you, and then you have accomplished what surgery would have accomplished, only you've done it all in the cath lab, and they, knock on wood, go home the next morning. And so this is a patient that we've done a Melody valve implant in here at Children's. This is a person with a homograft, and unfortunately it's really gotten tight on him. A combination of the patient's own immune reaction to it and tissue ingrowth. You can just see the difference in caliber between the pulmonary arteries and the outflow tract. This is way too small. This guy's 15. It's way too small. And so I'm going to skip to the money part of the procedure, because this is a fairly involved procedure. It's about 6 or 8 different balloon dilations, because you take it up very slow, trying to prevent complications or problems. So this has already been dilated several times. It's had a bare metal stent put in, and then this very dark stent is the platinum stent that the Melody valve is mounted on, and this is the very last inflation, taking the valve up to its final diameter. And then here is the final product. Now you can see a couple of things here. You can see the caliber of the vessel is much better, and you'll have to take my word for it that the pressure between the right ventricle and the pulmonary artery was excellent. But the other thing you can see is that the contrast doesn't leak back into the right ventricle anymore, which means there's a valve in that stent which is doing its job, because he's not getting any backward flow. I'm injecting contrast at a high rate into the pulmonary artery, and when the heartbeat pauses, the valve closes, and none of it goes back into the ventricle. So it's not leaking at all, even with a stiff wire and a catheter across it that's partially holding it open. So that's great. That's exactly what you want to see. So with all of these products, one of the things we worry about is we've got all this stuff to be more aggressive. Big Atlas balloons and cutting balloons and all this stuff. But, it's not without risk. It's not without some chance that you will actually tear the blood vessel. They're very sturdy. Scar tissue is very sturdy, but we worry about tears when we're going into these small homographs and things. So the next thing on the horizon is covered stents. Covered stents are Gore-Tex lined stents, so that when you lay up one of these stents and you have to hit it really hard, you're also laying in a lining of Gore-Tex on the outside of the stent, so that if the outside of that blood vessel tears under the pressure that you need to get it open, you'll never know, because you've laid a new lining on the inside of it, and you've got a nice smooth tube, just as if they had a surgical patch repair of that area. So covered stents are not available in the United States on the shelf. They are everywhere else. But they are available through specific protocols, and we're involved in all the protocols. The COAST protocol is the protocol for coarctation of the aorta. The PARCS protocol is the protocol for right ventricular outflow tract rehabilitation and Melody valves. And then the compassionate use protocol is a basket for other uses. And we've submitted patients under all three and implanted covered stents whenever we felt that it was the right thing to do. The only problem is that you're going through the FDA, it's a paperwork chase, and so unless it's an emergency. If it's an emergency, you can get it in 24 hours. But if it's not an emergency, it takes several months to get it, which hopefully will improve. So last bit, sorry to keep you. So the horizon is we'd love to do all this stuff and then have it go away. Because like I said, that little girl who's 3, she's got a very nice result on her right pulmonary artery, but she's got a metal stent in there that's going to be in there for the rest of her life. And wouldn't it be nice if we could have banged that blood vessel up to what it needed to be, let that vessel remodel, let it reshape and be the size it was supposed to be, and then have that stent dissolve and go away. So biodegradable intravascular products have an obvious desirability in pediatric patients where size is critical. And it's one of the things that really limits us, is we know we're putting stuff in forever, and when you're little, sometimes it's just not the right size. So the product on the left is a bioabsorbable ASD device, where the whole patch of this device is made out of a collagen matrix that once your own tissue grows over the top of it, the collagen matrix dissolves. And then you've got an ASD that's been closed, and there's no patch. It's closed with your own tissue. Unfortunately, the company went bankrupt. But the intellectual property was bought by another ASD company. Hopefully, it's still in the works. And then bioabsorbable stents, obviously that's very exciting, but not without risk. You can't have stents dissolving and breaking and then do fragments go downstream, and it's extraordinarily complex, but our division and our cath lab is participating in all of the bioabsorbable, right now it's just talks, but I'm a member of the Congenital Heart Disease Committee for the Society of Cardiac Angiography and Intervention, and there's a bioabsorbable task force that's on that, and we're on both the preclinical and clinical committees to work with that, but this is not to that stage yet.